Before we really get into the weeds today, let's just lay out the roadmap. If you take nothing else away from this, remember these three things.
Okay.
1, your skin is basically a molecular negotiation. It's between two completely different types of tissue, and if they ever stop talking to each other, the skin just fails.
It's a constant dialogue.
2, your fingerprints are, for all intents and purposes, a geological event. Think of it like tectonic plates buckling on your fingertips.
That's a great way to put it.
And 3, the reason some people have extra nipples, and yes, we are absolutely going to talk about that, is a direct throwback to our mammalian ancestors.
It's a literal connecting of the dots across our evolutionary history.
Exactly. Welcome back to the deep dive. Today we are tackling the integumentary system, which is the fancy medical term for skin, hair, nails, glands, and even teeth.
All the boundary tissues.
And to guide us, we're synthesizing 3 of the absolute Bibles of embryology: Langman's Medical Embryology, Moore and Persaud's The Developing Human, and I.B. Singh's Human Embryology.
These are the heavy hitters, for sure. And I think it's important we state our mission right up front. We are not just reading the textbook to you.
No.
This is an interpretation, a synthesis.
Yeah.
We want to help you visualize these really complex 3D processes so that when you do go back to the books, and you really should, the diagrams just click.
Right. Think of us as the Sherpas. We'll get you up the mountain, but you still have to do the hiking. Now, I want to start with a mental image. Anyone who's been in a delivery room or even just seen a realistic video knows this. You picture a newborn baby, and in the movies, they come out all pink and clean.
Which is a complete and total lie.
It's a total fabrication. In reality, a newborn is covered in this thick, white, greasy, almost cheese-like paste. It really looks like someone frosted them with cream cheese.
That is the vernix caseosa.
The vernix.
Yeah.
And it just begs the question, why? A fetus spends 9 months floating in what's essentially a hot tub of amniotic fluid.
Right.
You'd think they would come out all pruny, like when you fall asleep in the bath.
Right, but they don't.
No, instead they come out completely waterproofed.
And that grease, that vernix, is actually the perfect entry point for this whole discussion. It proves that the skin isn't just a wrapper. It's not a bag holding your organs in. It is a dynamic, active organ that is constantly interacting with its environment, even in the womb.
So let's peel back the layers, pun intended. When we look at adult skin, we see the epidermis on top, the dermis underneath. But embryologically, these are 2 totally different animals, aren't they?
Completely. And this is the fundamental concept of the skin. It's a collaboration, a marriage between 2 distinct germ layers.
Okay.
On the surface, you have the surface ectoderm. This gives rise to the epidermis. Think of this as, say, the tile on the floor.
Okay, the tile. I can picture that.
But underneath that tile, providing the structural support, the blood supply, the foundation, that's the dermis. And the dermis comes from mesenchyme.
Okay, let me stop you right there. Mesenchyme. This word gets thrown around constantly in embryology, and I feel like half the time people just nod along without really knowing what it is. Is it a cell? A fluid? What are we talking about?
That is a great question because the textbooks often assume you just know. Mesenchyme isn't a specific tissue like muscle or nerve. It's more of a description, a texture.
A texture?
Yeah, think of it as the packing peanuts or maybe the soup of the embryo. It's a loose, sort of jelly-like mesh of connective tissue that fills all the spaces between the developing organs.
So it's the filler material, the stuffing.
Exactly, and it's derived mostly from the mesoderm, which is that middle germ layer. So what you have is this sheet of ectoderm cells sitting on top of this soup of mesenchyme.
And they have to talk to each other.
They have to communicate constantly. It's like a construction site where you've got an architect on the roof and a builder in the basement, and they're on walkie-talkies. The mesenchyme, the builder, sends a signal up saying, hey, we've got enough foundation here, you can build a tower. That signal might be a molecule like FGF, fibroblast growth factor.
And the ectoderm on top, it hears that.
The ectoderm receives it, starts thickening, and then sends a signal back down, maybe using a molecule like sonic hedgehog or TGF-beta, saying, okay, I'm building down, you need to move the blood vessels closer.
So if one of those walkie-talkies runs out of batteries?
If the signaling pathway is broken, the skin just stops developing. It's a dead end.
So it's a reciprocal induction. They literally build each other.
Precisely.
Let's trace the timeline on this. At the very beginning, say week 4 or 5, we're just talking about a single layer of cells, right?
Right. A single layer of surface ectoderm over that mesenchyme. It's incredibly fragile. But very quickly, usually in the 2nd month, it divides.
Okay.
You get a basal layer at the bottom, which is the germinal layer that will keep making new skin forever. And you get a temporary layer on top called the periderm.
The periderm. sometimes called the epitrichium in the older texts. What's the point of this layer? It sounds temporary.
It is temporary, but it's absolutely vital. Think of the periderm as a scaffold, or maybe a disposable hazmat suit for the embryo.
A hazmat suit?
Well, remember, the embryo is floating in amniotic fluid. And later in pregnancy, that fluid contains fetal urine and even bile salts. It's not exactly pure spring water.
So the periderm is literally protecting the baby from its own pee.
Essentially, yes. The periderm cells keratinize, they get tough, and they create a barrier so the delicate developing skin underneath isn't macerated or, dissolved by the fluid.
Okay, but then what happens to it?
Here's the fascinating part. These cells are programmed to die.
Planned obsolescence.
Exactly. As the true epidermis forms underneath it, developing all those classic layers we learned in histology, like the stratum spinosum and granulosum, those periderm cells on top just act as a shield. Then, once the real skin is ready, they slough off, they shed into the water.
And this brings us right back to the cream cheese.
It does. That cheese, the vernix caseosa, is a mixture of those dead, shed periderm cells and the oil, or sebum, from the baby's brand new glands. It's a high-tech bioshield.
So it lubricates the skin for birth and protects it from the fluid.
Correct.
Now, you mentioned earlier that this is a programmed process. What happens if the program crashes? What if that periderm layer just decides, you know what? I'm not shedding.
This is a critical clinical correlation that you'll find in more. If the periderm persists, you get a condition called a collodion baby.
Collodion, like the old-timey glue.
Exactly like that. The baby is born encased in this tight, shiny, parchment-like membrane. It really looks like they've been vacuum sealed in plastic wrap, or like a sausage casing.
That sounds incredibly dangerous for a newborn who needs to take their very first breath.
It is. I mean, to think about the mechanics of breathing, you need your chest to expand.
Right.
If you are wrapped in a rigid sheet of cellophane, you can't expand. It physically restricts respiration. Now, usually this membrane cracks and peels off over a few weeks, but it leaves the baby very, very vulnerable to infection and dehydration in the meantime.
And there's an even more severe version of this, isn't there? I've seen pictures of harlequin ichthyosis, and honestly, they're hard to forget.
Harlequin ichthyosis is the most severe form of these keratinization disorders. It's caused by a mutation in a gene called ABCA12. And this gene is responsible for transporting lipids fats into the top layer of the skin.
So it's like the mortar between the bricks is missing.
That's a perfect analogy. Without those lipids, the skin barrier completely fails. The body panics and tries to overcompensate by just producing massive amounts of skin. The baby is born with these thick, diamond-shaped plates of armor, separated by deep red fissures.
It looks like a suit of armor, but not in a cool way.
No, it's catastrophic. The skin is so tight it pulls the eyelids inside out, that's called ectropion, and the lips outwards, eclabium. And again, that rigidity constricts the chest. These babies used to almost always die from respiratory failure or infection. Now, with modern intensive care, survival is becoming more common, but it really highlights a profound point. Shedding skin isn't just about making dust or, housekeeping. It is a genetically regulated, life-sustaining process.
It's so interesting to think that making skin is as much about the destruction of cells as it is about their creation.
Absolutely. Life requires a balance of growth, and apoptosis programs cell death.
Okay, let's move down a level. We've talked about the epidermis, the tile. Let's talk about the dermis, the foundation. You said it comes from mesenchyme, but that mesenchyme isn't just one thing. Where exactly does it come from?
This is where a book like Singh is very helpful because it breaks it down so clearly. The origin of the dermis depends on your zip code. It depends on where you are in the body.
Okay, map it out for us.
So if we're talking about your arms, your legs, your body, the dermis there comes from the lateral plate mesoderm.
Okay.
If we're talking about the skin on your back, it comes from the paraxial mesoderm, specifically the dermatomes of the somites.
And for those who might have forgotten their basic embryology, a somite is?
A somite is one of those little blocks of tissue that run along the spine of the embryo. You can think of them as the vertebrae starter pack. The back part of that block, the dermatome, becomes the skin of your back.
Got it. So limbs are lateral plate, back is somites. What about the face? The face always seems to be different.
The face is the rebel. The dermis of the face and the neck comes largely from neural crest cells.
Ah, the neural crest, the so-called fourth germ layer.
The great explorers of the embryo. These cells migrate from the developing spinal cord all over the body. And because the facial skin comes from neural crest, it helps explain why many genetic syndromes that affect the face also affect the brain or the heart.
They share that common origin.
Exactly.
Now, around the third or fourth month, this dermis starts to get a little pushy.
It does. It starts to push upwards into the epidermis, forming these little finger-like projections. We call them dermal papillae.
And the epidermis pushes back down.
Yes. The epidermis pushes down with what we call rete ridges. It's like interlocking your fingers. This massively increases the surface area between the two layers.
Which is important for what? Why do we need that much surface area?
Two main reasons. One is mechanical adhesion. If the interface were just flat, your skin would literally slide off like a loose glove every time you grip something tightly. The ridges lock the layers together.
And the second reason?
Nutrition. Remember, the epidermis has no blood vessels of its own. It's avascular. It relies on diffusion from the dermis below. More surface area means better feeding, better communication.
And this interlocking gives rise to one of the most unique features of human anatomy, fingerprints.
The technical term is dermatoglyphics, and the formation of fingerprints it's really a physics problem.
Physics? I always thought it was just genetics.
It's both. Here's how it works. In the fetal fingertip, you have these little cushions called volar pads. Between week 10 and week 19, the basal layer of the epidermis starts growing much, much faster than the dermis underneath it.
So the top layer is outgrowing the bottom layer.
Right. And because it has nowhere to go, it buckles. It folds. Imagine trying to shove a very large tablecloth onto a very small table. It's going to wrinkle. Those wrinkles are your fingerprints.
That is a great visual. So the pattern, whether it's a loop, a whorl, or an arch, that depends on the shape of the underlying cushion, the volar pad, at the moment the buckling happens.
Exactly. If the pad is high and round, you're more likely to get a whorl. If it's low and flat, you might get an arch. This is why identical twins have similar fingerprints, but not identical ones.
Because even though their genetics are the same, the exact physical pressure and the growth rate in the womb might vary just slightly between them.
Precisely. It's chaotic in the mathematical sense of the word. And because these patterns are set in stone or, well, set in skin by week 19, they become this permanent fossil record of your early development.
Which is why they have medical relevance beyond just forensics.
Yes. For example, in Down syndrome, trisomy 21, the growth of the hand is different. This leads to very characteristic ridge patterns, like a single transverse palmar crease, the so-called simian crease. If you see abnormal dermatoglyphics, it tells you something happened, either genetic or environmental, during that critical 10 to 19-week window.
Moving from texture to color, we tend to think of skin color as a property of the skin itself, but the cells that make the pigment, the melanocytes, they're actually immigrants. They don't belong there originally.
They are an invasive species in the best possible way. Melanocytes are another derivative of the neural crest.
Those travelers again.
They start near the neural tube, and they have to migrate a very long distance through the mesenchyme to get to the epidermis. They usually arrive around day 40 to 50 of development.
So what happens when they get there? Do they just turn into regular skin cells?
No, they remain distinct. I like to use the analogy of a painter and a canvas. The skin cells, the keratinocytes, they're the canvas. The melanocyte is the painter.
But the painter is seriously outnumbered.
Vastly. One single melanocyte has to provide color for about 36 keratinocytes.
Yeah.
So to do this, the melanocyte develops these long, tentacle-like arms called dendrites.
Yeah.
It manufactures pigment granules, melanosomes, and it literally injects them into the neighboring skin cells.
Wait, it injects them?
Yes. It's a process called cytokine secretion. The skin cell literally eats the tip of the melanocyte's arm to get the pigment package.
That is wild. It's force-feeding them color. So let's look at the pathology here. What's the real difference between albinism and vitiligo? Because to the naked eye, they both just look like white skin.
It's a difference in the supply chain. In albinism, specifically oculocutaneous albinism, the melanocytes are there, the painter's on the job site, but his paint factory is broken.
He has no paint.
Right. Usually they lack the enzyme tyrosinase, which is essential to make melanin. So the cell is present, but it's just clear.
Okay. And vitiligo?
In vitiligo, it's an autoimmune condition. The immune system attacks and destroys the melanocytes. The painter has been fired. Or, well, assassinated. So you end up with patches of skin with no melanocytes at all. The factory is gone.
Then there's piebaldism. I always think of the character Rogue from X-Men, with the white streak in her hair.
That's a classic presentation, a white forelock. Piebaldism is usually due to a defect in the migration or the proliferation of those neural crest cells. The explorers simply didn't make it to that one specific spot on the forehead.
Got lost on the way.
Exactly. It's a map error during development.
Okay, let's shift gears. We've covered the surface pretty well. Now let's talk about the things that grow out of the skin. Or, actually, more accurately, things that grow in. I'm talking about hair.
Hair is a perfect example of the invasion theme of this whole topic. We think of hair growing out, but embryologically, it starts as the epidermis deciding to invade the dermis.
Walk us through the stages.
It starts with what's called the hair germ. The basal layer of the epidermis just thickens and pushes down. Then it becomes the hair peg, a solid rod of cells digging deep into the mesenchyme.
What's it digging for?
Resources. The bottom of that peg expands to form the hair bulb. And this bulb then wraps itself around a little cluster of mesenchyme called the dermal papilla.
The word papilla keeps coming up.
It's crucial. The dermal papilla contains the blood supply and the nerve endings. Think of the hair bulb as a mouth, and it's swallowing this ball of blood vessels to feed itself.
So when you pluck a hair and you see that little white bulb at the end...
You just ripped it away from its food supply.
Ouch! So the epidermis, the hair, hugs the dermis, the papilla, and that signal tells the hair to start producing the actual shaft.
Yes. The cells in the bulb start to keratinize and stack up, pushing this column of dead cells upwards, which we see as the hair shaft emerging from the skin.
Now, the first hair we grow isn't the hair we have as adults.
No, not at all. Around 12 weeks, the fetus develops lanugo. It's this extremely fine, soft, unpigmented hair. It covers the entire body except for the palms of the hands and the soles of the feet.
It makes the baby look a little bit like a peach.
Or a little fur ball, yeah. And it has a function. Remember the vernix? The cheese?
Uh-huh.
The lanugo acts like Velcro. It holds the vernix in place on the skin so it doesn't just wash away into the amniotic fluid.
That makes perfect sense. It's like a reinforcement mesh, and usually this lanugo sheds before birth.
Usually.
Yeah.
But sometimes in premature infants or in certain genetic conditions like hypertrichosis, the lanugo persists. In extreme cases, historically called werewolf syndrome, people can retain a full coat of this hair. It's essentially a failure to switch from the fetal hair program to the adult hair program.
And attached to every little hair is a muscle, the erector pili.
The goosebump muscle.
What's unique about this muscle's origin?
Well, the hair itself is from the ectoderm, but the muscle is smooth muscle, so it comes from the mesoderm of the dermis. It attaches to the side of the hair follicle, and when it contracts, it pulls the hair perpendicular to the skin.
So it stands at attention.
Exactly. In animals with thick fur, this is useful. It traps a layer of air for insulation or makes the animal look bigger to scare off a predator. In humans, it just gives us bumpy skin when we watch a scary movie. It's a vestigial reflex.
Okay, let's talk about nails. Moore and Prasad have a really specific and useful clinical tip involving nails.
This is a great ready reckoner for doctors in the delivery room. Nails start developing around 10 weeks, but they migrate very, very slowly from the base of the finger towards the tip.
It's a slow crawl.
Very slow. The fingernails reach the fingertips by 32 weeks of gestation. The toenails, which are always a bit behind, reach the tips by 36 weeks.
So if you're delivering a baby and you look at their hands and the nails haven't reached the very edge of the finger...
You know immediately that baby is likely premature, almost certainly under 32 weeks. It's a fantastic visual stopwatch for gestation.
I love those little clinical hacks. Okay, moving on to the glands. We have three main types to discuss. Sebaceous for oil, sweat glands, and mammary glands for milk. And they're all related, aren't they?
They are all downgrowths of the epidermis. Let's start with the sebaceous glands. These usually bud right off from the side of a hair follicle. They produce sebum.
The oil.
But the way they produce it is, well, it's violent. It's called holocrine secretion.
Oh, break that down for me.
Holo implies whole. So in most glands, a cell makes a product and sort of leaks it out. In sebaceous glands, the cell fills itself with fat until it literally bursts and dies. The secretion is the dead cell.
That seems incredibly inefficient. Why would the body design a system where the factory worker has to die to ship the product?
It does seem wasteful energetically, but it's the most effective way to deliver a massive lipid-rich payload all at once. You aren't just dripping oil, you are slathering it. And remember, this dead cell slurry is what mixes with the periderm to make that vernix.
Okay, so sebaceous glands are on a suicide mission. What about sweat?
Two main types, eccrine and apocrine. Eccrine glands are your cooling system. They open directly onto the skin, and they work right after birth.
These are the ones that make us sweaty when we're at the gym.
Correct. But apocrine glands are different. They develop from hair follicles, just like the sebaceous glands, and they are only found in specific areas. The armpits, the groin, and around the nipples.
Then they don't work in babies.
No. They are totally dormant until puberty. They're activated by the hormonal surges of adolescence.
And they're the ones that smell.
Well, actually, the secretion itself is odorless and kind of milky, but it's very rich in proteins and fats. When it hits the surface of the skin, the bacteria that live there start feasting on it.
Oh.
The smell we associate with body odor is actually the bacterial waste products.
Lovely. So body odor is basically bacteria having a dinner party in your armpit.
That's a pretty accurate description. And this links perfectly to the mammary gland, because chemically and structurally, a mammary gland is just a highly modified apocrine sweat gland.
Wait, you're saying milk is just modified sweat?
In an evolutionary sense, yes. It's a protein-rich secretion that's been adapted to nourish rather than to cool or signal.
This brings us to the milk line. This is one of those concepts that just blows people's minds when they first hear it.
The mammary crest. In a 4-week-old embryo, you can see a thickened line of ectoderm running all the way from the armpit, down the chest, down the abdomen to the groin, on both sides.
Like a set of railroad tracks.
Exactly. And in many mammals, think of dogs, cats, pigs, this whole line stays active, and they develop rows of nipples along it.
Right.
In humans, that line is supposed to regress and disappear, except for the 2 spots on the chest where the breasts will form.
Supposed to. I hear the caveat in your voice.
Right. Because often, it doesn't disappear completely.
Yeah.
And you can get polythelia supernumerary nipples.
Extra nipples.
Yes. They can appear anywhere along that old milk line. The most common spot is just below the normal breast, but they can be in the armpit or even down in the groin.
And they're often just mistaken for moles.
Very often. But here is the kicker, and Moore really highlights this. There is a known statistical association between having extra nipples and having renal anomalies. Kidney problems.
Why on earth would nipples be connected to kidneys? They're nowhere near each other.
It's all about timing. The kidneys in the mammary crest are developing at the exact same time around week 4 to 6. So if there's a teratogen, a drug, or a genetic glitch that hits the embryo during that critical week, it can affect everything that's actively developing. The extra nipple is a red flag. It says, hey, while you're here, you should probably check the kidneys.
That is fascinating. The skin is acting like a dashboard warning light for the internal organs.
It really, really is.
Before we wrap up the appendages, we have to talk about the one that is maybe the hardest to visualize. Teeth.
Teeth are the boundary that bites. And they are complex because they require this very precise dance between the oral ectoderm on the surface and the neural crest mesenchyme deep to it.
Okay, we have 3 stages here. Bud, cap, and bell. And honestly, when I read the text, these all blur together. Can you help us distinguish them?
Let's just visualize the shape. Stage 1, the bud. The skin of the jaw, the dental lamina, thickens and pushes a simple round bud down into the bone.
Like a drop of water hanging down.
Perfect. Stage 2, the cap. The bottom of that bud hits a ball of neural crest cells, which is the dental papilla. The bud indents. It starts to look like a little beret sitting on someone's head.
So the ectoderm is the cap and the mesenchyme is the head wearing it.
Correct. Stage 3, the bell. The cap grows deeper and wraps around that ball, looking like an old-fashioned church bell. This is where the real differentiation happens. The cells lining the inside of the bell become ameloblasts.
And ameloblasts make enamel.
Right. And the cells of the head underneath the papilla, they become odontoblasts. And they make dentin.
So enamel is ectoderm, dentin is mesenchyme.
You've got it. And this leads to a crucial clinical warning. Enamel is a mineralized tissue. It absolutely loves calcium.
And this is where tetracycline comes in.
Exactly. Tetracycline is a broad-spectrum antibiotic. Chemically, it's a chelating agent, which means it binds to calcium ions. If a pregnant woman takes it, or if a child under the age of 8 takes it, the drug flows into the developing tooth and binds to the calcium in the enamel and dentin.
It gets locked into the stone as it's being formed.
Permanently.
Yeah.
It causes these brownish yellow bands of discoloration on the teeth. You can't brush it off. It's part of the molecular structure of the tooth itself. This is why we are so careful with certain antibiotics in pregnancy. The teeth act like a geological record of chemical exposure.
One last quick thing on teeth, natal teeth.
Right. About 1 in 2,000 babies is born with a tooth already erupted.
That sounds like an absolute nightmare for breastfeeding.
It is painful for the mother, and it can actually ulcerate the baby's tongue. But the real danger is aspiration. These teeth often have very poor roots. They're wobbly. If that tooth falls out, the baby could inhale it into their lungs. So quite often, we have to pull them.
We've covered so much ground here. I want to try to synthesize this. We've talked about hair, teeth, sweat glands, and nails as all these separate things, but they're really all the same thing, aren't they?
They are variations on a theme. They're all ectodermal appendages. They all form by the surface folding down or invading the deep.
Which means if you have a genetic defect in the ectoderm,
You get ectodermal dysplasia. This is a syndrome where the basic app for building any of these appendages is broken.
what does a patient like that look like?
Just connect the dots. Their hair is sparse and thin, a hair defect. Their teeth are missing or peg-shaped, a tooth defect. Their nails are brittle. But the most dangerous part? They often lack sweat glands.
They can't cool themselves down.
Exactly. They have severe heat intolerance. In the summer, they can overheat to dangerous, even fatal levels. It's a perfect example of why embryology matters. If you see a kid with funny-looking teeth and thin hair, you have to ask about their ability to sweat. You have to treat the whole system.
And finally, let's just briefly touch on hemangiomas. These are super common.
Very common. These are benign tumors of the blood vessels in the dermis. The strawberry hemangioma is the classic one, that bright red raised patch. They usually grow for a little while and then regress on their own.
But sometimes they can signal something deeper.
If you see a port wine stain, which is a flat purplish mark on the face, and it's specifically covering the area around the eye and forehead.
The trigeminal nerve distribution.
Right. You have to worry about Sturge-Weber syndrome. This can involve similar vascular malformations inside the brain, which can cause seizures and calcifications. And the skin is the window. A mark on the surface can tell you about the wiring underneath.
So let's bring it all home. We started with the cheesy armor of the vernix. We've ended with the dangerous lack of sweat. What's the big takeaway for the listener today?
I think the takeaway is to stop thinking of the skin as just a wrapper. It is an intelligent interface. Think about the harlequin fetus we discussed. It teaches us that the shedding of skin isn't just waste disposal. It is a vital, active process required for life. If we can't shed our old skin, we are literally trapped.
It's a profound thought. We have to constantly let go of the old self, literally, cell by cell, just to survive.
Exactly. And consider the fingerprint. Before you are even born, before you've taken a single breath, the physical pressures of your own hands interacting with your mother's womb have written a unique identity card on your fingertips that no one else in history will ever have.
The body keeps the score.
Yeah, it really does. It records our history from the chemical bands in our teeth to the ridges on our hands.
Well, next time you look in the mirror, maybe check your philtrum, that little groove above your lip, and remember the neural crest cells that migrated there. Or check your armpits and be grateful your apocrine glands waited until puberty to kick in.
And maybe count your nipples. You never know.
Maybe do that in private. If you want to see the diagrams of the Bell stage of the tooth or the hair peg, and you really should because they are beautiful structures, open up the Integumentary system chapter in Singh or more.
Visualizing that invasion makes all the difference.
Thanks for diving deep with us. We'll see you on the next one.
Stay curious.